So Lewy body dementia encompasses two main scenarios. One would be someone who started with symptoms of Parkinson's disease and then at least a year later started to have problems with their thinking, memory, other cognitive functions. The other scenario is what we call dementia with Lewy bodies, where the cognitive issues happen in the very first year of symptoms, may or may not have had other problems that resemble Parkinson's. So both Parkinson's disease dementia, Parkinson's with dementia, and dementia with Lewy bodies all fall under that diagnosis of Lewy body dementia. And they're both really covered well by the Lewy Body Dementia Association. That's a really good resource, both to get up-to-date information about new research and to connect with support groups across the country. So there are additional online support groups and videos offered there as well as through the PMD Alliance. So how does someone come to the diagnosis of Lewy body dementia as opposed to Alzheimer's? Well, first of all, if a person starts with other problems in their thinking than just memory loss, usually Alzheimer's, one of the main problems, people get disoriented, they have trouble remembering things, storing new information. They may still have good memory for things that happened a long time ago until they're very advanced in their course. With Lewy body dementia, whether it's related to Parkinson's or the other type, what I refer to as DLB, dementia with Lewy bodies, referred to as DLB for short. With these, very often there are different areas. It's a slower processing speed, takes longer to process what you want to say. There are problems with attention, and very often problems with visual spatial perception. So people kind of misjudge where they're stepping. They may kind of have trouble handling items like a remote control or a telephone. They have trouble sorting out the position of those objects. One of the other key features is there's a fluctuation in the level of attention and disorientation. So two key features would be if the person seems to have staring spells where they're really out of it, they're not all there, and then other times they're very alert. Another example would be periods of illogical speech where they say things that really don't make sense for the situation, then other times they're speaking clearly. So those are what we call cognitive fluctuations. Those would be a big red flag if you're seeing them early on in the course of the cognitive decline, the problems with thinking, memory, other cognitive functions. The other big red flag would be irrespective of taking medication. If the person that has hallucinations that emerge that don't seem to be directly due to being ill, for example, sick with an infection, or due to medications, particularly pain medicines. If that person starts developing hallucinations spontaneously early in the course of their dementia, that's another red flag. This could be Lewy body dementia. The other important one is what we call the motor features. Doctors like to use the word Parkinsonism. It sounds fancy, but just a way of saying this person has slowing of their movements along with either tremor or muscle rigidity or gait and balance problems. So that would be another feature, along with at least one of the other two, that would be used to help us make that diagnosis. Another feature that is an important clue, but isn't definitive, what's much more common in Lewy body than with Alzheimer's, is a condition called Rem Sleep Behavior Disorder. This is a condition where during active dreaming, when only the eye muscles should be moving, that's why we call it rapid eye movement or REM stage, other muscles that should be calm, paralyzed, are moving in a way that reflects what the person's dreaming about. So they may scream out loud, they may hit their arms out or actually throw punches if they're dreaming about a fight. They may grab the person or the pet next to them if they dream about an altercation. They may even bicycle their legs if they dream about running away from a bear or running after someone. Some people even fall out of bed because of this or hurt their bed partner or even their pet. They even can hurt themselves, particularly if they're jumping out of bed. This is a condition that even if we're not sure what the diagnosis is, it's important to bring up with your treating physician because there are treatments that can calm it if there's a risk of injury related to it. And finally, if the doctors really aren't sure, they're not sure if this is Alzheimer's or Lewy body dementia, there's some very subtle slowing down, hard to really say for sure that's Parkinsonism. There is a special scan some of you may already be familiar with called the DAT scan. This is a scan that looks for a loss of cells in the brain that are usually lost in Parkinson's or with DLB, dementia with Lewy bodies, that produce dopamine. Another important feature to know about and to be proactive in warning doctors at the hospital about if you or your loved one already have the diagnosis is what's called neuroleptic sensitivity. This is a situation where drugs in the antipsychotic category or some of the anti-nausea drugs can cause a profound worsening of a person's motor symptoms or even their cognitive state, where they seem more confused, disoriented. And so we generally try to avoid most drugs in those categories in someone where we've made or are considering a diagnosis of Lewy body dementia. So that's just the kind of the basic overview of how we diagnose and some of the key features to know about. As far as symptoms, first of all, the same medications that are used to treat memory loss in Alzheimer's disease can sometimes be even more helpful for the fluctuations in attention, slowed processing speed, and if it's present, memory loss in individuals with Lewy body dementia. These are medications like Exelon, Aricept, donepezil, Razodine, or galantamine. Exelon is also known as rivastigmine. These medications can appear to slow the progress of the memory loss because they improve it, but then it does eventually continue to get worse for many people. This is why several groups, including our center, Barrow Neurological Institute, have been partnering with a company called Axovant that is testing a potential new treatment that can boost the effect of medications we already have. There's also another company called Biotie that's testing a very similar medication in Parkinson's disease dementia. So whether someone has one or the other type of Lewy body dementia, both Parkinson's disease dementia and DLB, are both areas where new treatments are being tested for the cognitive issues. The other issues to address can be if a person has hallucinations that are disruptive. They're not able to separate what's real and what's not. Sometimes they even believe things that aren't true, like that there's an intruder in the house, or that people are planning things against them, planning to put them in a nursing home even though they're doing okay at home. This is where medications can be helpful, but need to be chosen carefully. Sometimes stopping medications that worsen confusion may be a good first step before adding more medicine. Many of the medications that we use to treat other conditions, particularly bladder symptoms, but also even antidepressants, have properties that block the same chemical we're trying to boost with the memory medications. It's called acetylcholine. So that property of medications we call anticholinergic side effects. So medications like oxybutynin for the bladder, amitriptyline for depression or for sleep, these are just examples of where sleep aids, antidepressants, bladder medicines may actually be making memory or confusion worse. When we make a decision to treat a patient, we usually use medications that either don't block dopamine in the brain at all or come rapidly off the receptors for the dopamine. That's because we don't want to worsen or cause motor symptoms or worsen the cognitive symptoms of Lewy body dementia. So the most commonly used medications are Seroquel, which has a generic called quetiapine. And even though it's mainly approved for Parkinson's hallucinations, the drug Nuplacid is also commonly used in Lewy body dementia. In fact, if someone has a lot of problems with movement, they have stiff muscles, they're stiff when they're walking, so they shuffle and they fall because they're shuffling. They just feel generally lousy because they're so slow and stiff. That can even contribute to swallowing difficulties and drooling. This is where medications for motor symptoms can be helpful, but we have to use them with caution. And so usually your doctors will start with the carbidopa-levodopa preparation. That levodopa replenishes dopamine. Occasionally that can bring out the hallucinations or worsen them, and it may make sense to treat that side effect with a second medication in order to help the person with Lewy body dementia tolerate the motor treatment. If a person is taking a medication other than levodopa and it's causing hallucinations, the first step is usually to switch off that one or lower the dose before adding more medicine in most cases. And it's really case by case. But medications, particularly artane and trihexyphenidyl, but also Mirapex, pramipexole, Requip, ropinirole, and the Nupro patch are all more likely to bring out hallucinations. Any questions so far on those treatments or questions? And am I still showing up okay?
You are showing up okay. We do have a couple questions here for you. One is about the Rem sleep disorder. Is laughing out loud part of that?
Yes. So many people with Rem sleep behavior disorder will have more violent dream enactment. We're not sure why, but that seems to be more common in men than in women. They seem to shout louder and have more violent dreams. It's always the nicest guys have the more violent dreams. Yes, it does seem that for some individuals, they just talk and laugh out loud. Now, we're not sure. Nobody's really sure. If someone occasionally mumbles a few things in their sleep or does a brief chuckle in their sleep, what is that? This is something where there's a recurrent kind of really almost dangerous or violent dream enactment. That's where we really start to worry about treatment. But yes, if someone frequently laughs and talks out loud, even has a conversation that reflects what they're dreaming about, that certainly could be Rem sleep behavior disorder.
Okay. And how about, there's a question about, can you have some of these symptoms but not have Lewy body?
Yes. Thanks for your question. One of the important questions also is, can this happen first before someone's diagnosed with anything else? And the answer appears to be yes. There are many individuals, it may be as many as a few percent of the population over 50, that do have just Rem sleep behavior disorder, but do not have Parkinson's or Lewy body dementia or something in that category. However, that does seem to be linked with a higher than average risk of those conditions. Another condition, in addition to Parkinson's and Lewy body dementia, that seems to be linked is called multiple systems atrophy, but fortunately much less common, more aggressive illness.
There was a question about MSA.
So we don't know why it increases the risk. We don't yet know definitively when someone first develops the symptoms how to predict exactly what their risk is. And so many centers around the world are enrolling people who have the condition to be monitored once a year for any evidence of a movement disorder or a memory disorder, to not only to monitor, but also to get them involved in research to help answer that question. Our group, which is a collaboration with Mayo, Arizona, and the Barrow Neurological Institute at the Brain and Body Donation Program, is starting now this year to enroll people who have REM sleep behavior disorder with frequent dream enactment to be followed once a year through a research study. And we do encourage people to sign up for our Brain and Body Donation Program for that study to help us answer the question, why does a sleep condition lead to a memory or movement disorder? So we really don't know yet.
Okay, that's great. And what we'll do, we will make sure that people have the contact information so they know how to contact you for the research as well as for the Brain and Body donation program. That's great. There's a question too, can individuals have Lewy body dementia with Huntington's disease?
To my knowledge, REM sleep behavior disorder has very rarely been reported with Huntington's disease. More frequently with Huntington's disease, we do hear complaints about insomnia. Okay. So to my knowledge, it is not strongly linked with Huntington's, or not as strongly linked with Huntington's as with these other three, MSA, Parkinson's, and Lewy body dementia.
Okay, but Lewy body dementia, does that coincide with Huntington's also, or that separate?
Really not. Okay. Can someone with Huntington's also develop a separate neurodegenerative condition like Alzheimer's or Parkinson's? Yes, there are even reports of people who have Lou Gehrig's on top of Huntington's, and whether that's bad luck or just some type of a link between the two different genes involved, we don't know for sure.
Okay. There's another question. Do people with Parkinson and associated disorders become dangerous to those around them? I'm assuming that's related to the dementia, Lewy body dementia, and potentially the REM sleep disorder. But is there a potential of danger?
Yes. So if a person develops hallucinations with delusions, they're not able to separate what's real and what's not. They believe what they're seeing is a risk to them. They can misinterpret those hallucinations and act out in a way that's dangerous to others around them. Okay. I used to have a patient early in my career who would hallucinate people in the house and would keep a gun under his bed to protect him from the people he was seeing in the house. So if that kind of thing is happening, it's really important that we keep the guns in a safe location, or location where that person with hallucinations can't access them. That's just one example. Certainly, yes, with those dreams where a person acts them out, individuals can have very violent dreams where they injure the spouse, pet, or even themselves. So it's important to change the sleeping arrangements, even seek treatments if there's very violent dream enactment. And again, there are treatments that can be used safely. They don't necessarily need to be stronger antipsychotic drugs to treat the hallucinations and delusions. Most people, if we remove inappropriate medicines and we choose appropriate treatments, we can get the delusions, more severe hallucinations calm down enough so people aren't a danger.
Okay. Well, and I think you also this also brings up the importance of having the care partner or a person that's living with the person with the disease be a part of the conversation with the doctors so that those things surface. Mm-hmm. Yeah. How about, there's a question, is there a typical progression once dementia has begun with someone with Parkinson's?
I appreciate the question. That's another one that we need a little more research on. We're starting to get some information about this through, for example, through the Brain and Body Donation Program, that a proportion, not everyone, but a significant proportion, probably at least 40% of the patients who have Parkinson's and then develop dementia also have Alzheimer's. So there are some where the dementia is strictly due to the Parkinson's, others where they have both. And it may be that that combination causes a different course where people develop more severe memory loss and more frequent confusion, maybe even a faster course. That's one question we need to answer through research. how do we tell which type the person has, and then how do we predict what the course will be? I will say if someone starts with Parkinson's and then has gradual memory loss, progressing into mild dementia where it interferes with everyday activities, some people do continue to have a gradual progression over many years. There are others where it does seem to be a more aggressive illness. And this can be true both with dementia with Lewy bodies, where there's an early cognitive decline, or with Parkinson's disease dementia. So we still need more research to help us predict early in the course what we're looking at, because I understand most of our caregivers need to know how to plan the next few years. Is this something where the person's going to hang in there 5 or 10 years and still have good quality of life, or do they only have a few years left? Usually the rate of progression in that first year or so gives us a good sense of what to expect over the next few years. But you can't always tell just in the first few months.
And you know, before you jumped on, we talked about the difference between a general neurologist and a movement disorder specialist. And I think this really highlights the importance, we believe at PMD Alliance, to see a movement disorder specialist, a person, I mean, these are complex diseases. And so really seeing someone that just has really in-depth knowledge about these diseases, it's really important. So somebody's asking, are people with one of these disorders at higher risk for suicide?
So they're definitely at higher risk, whether it's Parkinson's, Lewy body dementia. These patients are definitely at higher risk for depression. So in general, at least 40% of our patients struggle with mood disorders like depression. Untreated depression can lead to suicidal thoughts and behavior. So yes, they are at higher risk. Depression is treatable, but sometimes we as doctors, when we've got so many different symptoms that we're working on, don't always ask about it. So, and it's also difficult to separate depression from apathy or low energy level due to motor symptoms. So apathy is that loss of motivation, trouble getting motivated to do everyday activities or participate in leisure activities. Once people are out and about doing things, they seem to enjoy them. The main difference with depression, it's important to bring up, is when you see someone seem sad, tearful, they are very negative, they keep expressing guilt, being a burden to other people. That's something that's best addressed early. You know, not to let that go on, not to let the doctor say, take this, I'll see you in 6 months. You know, we need to address depression when we see it, and that can really hopefully reduce the chance of suicidal behavior. I will say though, it's very uncommon. In my experience, I personally had one patient where it happened, in a Parkinson's patient who had just enough problems, you know, cognitive impairment, to where we had to take the keys away. He had to stop driving. And it was really unexpected for a family and for us. This isn't someone who had endorsed any evidence of depression, tearfulness, sadness, thoughts of guilt, feeling like a burden. And so I think this happens not just in Parkinson's patients, but even our loved ones who are just ill and want to have a way out, want to go on their own terms. That's something that you can't anticipate. And I'd say certainly the depression is a treatable problem that increases the risk.
Okay. Somebody wanted to know if Parkinson's disease leads to specific vascular dementia, specifically vascular dementia.
So we don't have clear evidence that Parkinson's leads to vascular dementia, but there may be evidence now that people who have cognitive problems that develops after they're diagnosed with Parkinson's, so Parkinson's dementia, may also have more multiple small strokes, or what we call white matter disease, so vascular causes of their dementia. So it may be that when people develop more cognitive decline with their Parkinson's, it's not just a progression of the Parkinson's, that they also develop either vascular dementia or Alzheimer's dementia.
Okay.
And again, this is something that we're still in the process of learning more about through our donors, through the Brain and Body Donation Program. We're able to do the cognitive assessments every couple of years, and then when people pass, we can determine if what we were seeing with cognitive problems relates to a vascular dementia on top of Parkinson's.
Okay. And what differences would there be in the treatment to prolong functionality between Parkinson's disease and Lewy body dementia?
Okay. So it's important to emphasize we do not yet have a treatment that has been proven to slow the worsening of motor symptoms of Parkinson's, the dementia, and any type of Lewy body dementia. The medications can appear to slow the progress because they
I think everybody can hear me. We lost him mid-sentence, so we'll see if he can join back on. I know we are getting close to the end of his time. It's such such an important topic that everybody has so many questions about. Let me see. Oh, here he is. Okay. Let's see.
So I'm sorry you lost me mid-sentence, but long story short, there's some limited evidence staying more physically and mentally active may slow the progress. We understand there are just some people have too many other medical conditions that really interfere with staying physically active. But that seems to be our best bet is regular exercise and then engaging the person in activities that exercise the mind. Certainly can't hurt. And as long as it's done with a medically approved exercise plan.
Yep.
And we don't have a medication that's proven to slow the progress of any of these illnesses yet.
So there's a question about therapy, and so you're talking about exercise, which is certainly one part of therapy. And without specifics, I'll just ask cognitive therapy, other kinds of therapies that help with this disease process. Do you have any thoughts?
Thanks for your question. It's really important to have what we call the multidisciplinary team, good communication between your doctors, but also referrals early when we see the first signs of a balance problem to work on physical therapy. When we see that a person's communication is really impacted or they're having swallowing difficulties, then we get a speech therapist involved. Speech therapist, if someone's having a lot of trouble with word finding difficulty, language problems, speech therapists can sometimes also advise on other approaches to improve communication. Occupational therapists can sometimes be helpful, particularly this is less of a problem in, for example, in Sun City, where most of the homes already are adjusted to improve safety, but occupational therapists can be very helpful to recommend ways to improve safety, reduce fall risk in the home. If there are tremors that aren't well controlled with medication, but interfere with everyday activities, the occupational therapist may have some really helpful recommendations with devices to reduce impact of the tremor on everyday activities.
Yeah, a team really, I think you're right. A team is really the key, and we're really lucky. I mean, we have a lot of resources. And if you live in a place, I'll just say this, if you live in a place that you don't know where the resources are, you can always reach out to us. We will do our very best to find any resource that's available and link you up. By the way, some of you may or may not know that if you have a question that you want to submit privately, you can do that. And so some of these you're reading, you're probably wondering where I'm getting them from. So you can submit private questions too. So the question is about white matter, something you said about white matter and strokes.
Yeah, so the question we had earlier was about vascular. I'm getting a little feedback.
Oh, we can hear you. Oh, nope.
Okay.
There you are.
Okay. Vascular dementia can be caused by multiple strokes, but can also be caused by problems with small blood vessels that provide ventilation between cells in the brain. That inflammation called white matter or myelin. So when that wears down, it's something the MRI or CAT scan in the brain. That may be something that also contributes to cognitive problems in.
Okay, and I know we're getting a little bit of feedback. Someone was asking, the physical occupational speech therapies, they improve function, but they don't necessarily slow the progression of the disease. There's not necessarily something that's going to cure or really, absolutely slow the progression of the disease. That's a correct statement? Okay. And then, and I know we got to get you going because we've got to get you back to clinic because you'll have patients waiting for you. But what I don't know is if we can still hear you, if you want to just say a few more words about the research study you're doing, because I think it's wonderful to finally have some research happening with this. We'll see if you can talk about it though. Oops, nope, can't hear you.
He's muted.
All right. Now you can hear me?
Yep.
Okay. I'm muting my microphone. So let me know if there's still feedback.
Okay.
Okay. Just do that if there's still feedback.
Okay, sounds good.
So first of all, the medications that are being studied right now are medications aimed at boosting the effect of existing treatments for Lewy body related attention memory problems. So donepezil, Aricept, Exelon, rivastigmine, those type of medications. So whether it's someone with Parkinson's disease dementia or dementia with Lewy bodies, we really need to partner with patients and their caregivers to determine if these treatments really work. Really encourage you to go to our website, bannershri.com, to learn more about the studies and who to contact to get involved. In the near future, we may also get involved in research trying to determine what's the best treatment for the Rem sleep behavior disorder, acting out of dreams in people who have Lewy body dementia. There also are some existing treatments available. So we're certainly interested in hearing from you if that's a real symptom that's causing a lot of difficulties. And we can either get you involved in the research or recommend treatments. We see it through the clinic. I think the most important program and the reason that I moved here from my previous institution up at the University of Utah is the brain and body donation program. Anyone with diagnosis of Alzheimer's, Parkinson's, or dementia with Lewy bodies can participate. Now individuals who have Rem sleep behavior disorder but don't have a memory or movement disorder can also participate. And people are seen once a year for the research study and can sign up for either brain or whole body donation to help us answer the difficult questions, how to better diagnose these conditions during life when it really matters, while people are still alive, but also to understand how to identify them at the earliest possible stage and try to develop preventive therapies. Banner Alzheimer Institute and others are already involved in preventive therapies for Alzheimer's, but with what we learn from these programs, we may soon be able to start testing preventive therapies against Parkinson's or Lewy body dementia, particularly in people who have just REM sleep behavior disorder and nothing else. So I really appreciate the opportunity to speak to everyone. Let me know if there are any final questions.
Thank you so much. There's a couple comments. One, Melissa from HD Support and Care Network. They're one of our partners, and she just wanted me to tell you thank you for your time and valuable information. And can you tell us the website again? And I'm going to type it into the chat for everybody.
Sure. So it's Banner, SHRI.com.
Excellent. There it is. And you should also know, if somehow you don't get this down, you can go to our website, you can go to the physician partners, and you can find a picture of Dr. Shprecher, and now you know what he looks like, but it also has his name. And there's a link right below his name that will take you right to his, to the page where he's at. So you can click right on that and get directly to his website in case you didn't get that down. And someone else wants you to know that you've finally solved their REM problem. It's awesome. Thank you so much for doing this with us. This was our first lunch session, and it's obviously I think going to be something that's really popular, and it's also something that is certainly really needed. So, and we are so fortunate that you will help us and be part of this.
Thanks for having me. Thanks for all that you do.
Thank you all for being here. And next month we will, the fourth Wednesday, we'll have another lunch with docs, and we'd love to have you join us. And thank you again, Dr. Shprecher. Thank you, everyone. Have a really good day.